A little bit about me or as to what I currently do. I am I'm a professor and vice chair of the Department of Physical Medicine and Rehab here at the University of Kentucky. I have served in the role as medical director of our spinal cord injury unit since essentially 2006. I also serve as the medical director for post-acute care services for UK Healthcare, and that's just a bigger role as far as just really transitions of patients from acute care hospitals to rehab facilities. I have been at UK. Well, I came back to UK in 2004, so I've been here for a really long time. All right, so first and foremost, again, just in generality about spinal cord injury in and of itself. Incidence is about 54 per million, about 18,000 new cases per year. And obviously, the number of cases reported is kind of garbage in, garbage out, and really depends on the trauma registries and what is reported. So there's a lot of injuries, honestly, that I think, there's mild cases of spinal cord injury that comes into the ER that is unrecognized, and I'm on the receiving end of getting new trauma patients fairly frequently, or even get consulted in the rehab hospital where people did not recognize that the patient actually had a spinal cord injury as part of their polytrauma. So again, if that patient doesn't get registered, then you don't know that it happened per se. In the US, there's about anywhere, again, if you look at the demographics of the numbers, from about 294 to about 320,000 individuals living in the US with a spinal cord injury. Much more prevalent in our male population. And the reasoning or the thought for the reasoning behind that is the risk-taking behavior associated with males, more so than females. The mean age has increased significantly. When I went through residency, our mean age was in the mid-20s. I went to residency in the 90s. So yes, it has been a while, but at the same time, this age increase really reflects the fact that our general population is aging and living longer. So the incidence of spinal cord injury, especially in our aging population, is growing with time. From a race perspective, Caucasian, followed by African American, followed by Asian, and then Hispanic, and then others. Really, this is inherent to where you are practicing in the communities that you live in. So this will be a little bit variable depending on where you are. And then from a marital status perspective, given that majority of our patients are younger, a lot of them have never been married. There's about 35% or 37% rather that are married. And then the others who are separated, widowed, or divorced. Now, the interesting issue with marital status is those who are married at the time of their spinal cord injury, oftentimes their marriage actually does not survive the injury, in the sense that roles change, and your spouse becomes your caregiver, and in that, a lot of times marriages end, versus the marriages for people who get married after their spinal cord injury typically last significantly longer, just in the sense that those spouses realize what they are getting into, so to speak. And so really, for the better, for worse, they get that and will stick by their spouse and understand the world of spinal cord injury. So a little bit of a difference. We classify spinal cord injury into two big categories, essentially traumatic and non-traumatic. So your traumatic injuries are basically anything that is trauma related, meaning cervical, thoracic, lumbosacral fractures having to do with high speed injury. Doesn't necessarily just need to be high speed. It could be they fell down the stairs, versus they dove, versus they had a car accident, ATV accident, skiing accident. So something that required a little bit of speed. And then you get some patients where they had a trauma, like your elderly fall patient that might have just tripped and gone down a couple stairs. So you think, gosh, that's not so, that fall should not have caused this problem. But those are the patients that typically have an underlying myelopathy to start with. They probably had profound disc disease, joint disease in their spine to begin with, and then essentially the fall caused that issue to just present itself. We see a great number of those patients that we take care of. And then from a non-traumatic perspective, this is where spinal cord injury versus spinal cord disease kind of comes into play. So your motor neuron dysfunctions, spinal disease, infectious etiologies, we have seen significant uptick of epidural abscess and osteomyelitis, especially within the state of Kentucky. We went to a drug registry, essentially a reporting system, and then we passed a law that really shut down a lot of the pill mills in the state of Kentucky. But what that did was it took patients that were getting medications somewhat under controlled environment to then getting meds in a non-controlled environment versus actually, getting meds off the street. So, and then a lot more of the heroin coming about. So as a result of that, we have seen a huge amount of epidural abscesses since 2015. And then you've got some outliers like HIV, West Nile virus, that kind of stuff that will pop in as well. You have your underlying immune deficiencies, so your MS, transverse myelitis, neuromyelitis optica that will show up, your tumor patients, again, dysvascular patients. So that you'd say, well, how does dysvascular work in the world of spinal cord injury? So these are the patients that end up with spinal cord infarcts, whether it's because they've done a aortic repair or because the patient has had a lot of underlying surgeries in the past, they go back in. These folks have underlying diabetes, hypertension, other PID essentially, and then the changes that occur from a surgical perspective and anesthesia perspective. It doesn't take much for the patient to wake up with an acute paraplegia, and people are scratching their heads of like, why did this happen? And you really can't, you can't really find a good answer besides just going back and really reviewing the patient's history. And then you have other reasons for non-traumatic injuries, including metabolic or nutritional. And then you've got your hereditary patients. So your hereditary spastic paraparesis, for example, that we take care of. And really the polio, post-polio syndrome, although listed as part of this, realizing that that is a different etiology. But within spinal cord injury medicine, those of us who do spinal cord injury medicine also take care of patients with post-polio syndrome as well. So thankfully, we haven't seen an acute case of polio in forever, and hope to keep it that way. The issues that I contend with on a regular basis, whether it is on the inpatient side or outpatient side, as I do both, there are central themes to these patients. And again, it just is variable as to what extent of problem that you're dealing with. But bowel and bladder dysfunction are tremendous in our patient population in helping them establish a bowel and bladder routine. Interestingly enough, if, based on surveys that you've done of patients, it's not necessarily been from a quality of life perspective that I want to walk or I want to have hand function, but it's I want to have bowel and bladder control. Just because, when you're incontinent all the time, being able to leave your house, being able to be socially accepted and be out amongst others, the bowel and bladder issue is a huge, huge problem. So we will designate or create a bowel and bladder program depending on whether we have an upper motor neuron injury or lower motor neuron injury, as those are both different. And both scenarios are frustrating. It is extremely challenging to get people to accept the fact that they actually have to take part in this. I had a conversation earlier today with one of my gentlemen who said, "Oh, I absolutely cannot cath myself." And I said, "Well, no, it's not about can you, it's whether you want to or not." So again, just being patient with the patient to say, you know, I do this game basically to say you have homework, and your homework is to touch your catheter kit and just understand what that means before you actually have to try to cath the model before you catheterize yourself. And so in doing such, it just takes people a little bit of time to accept the fact that, okay, everybody's got to poop and pee. I got to figure out how I'm going to do this. And I want to regain my independence because I don't want my mother to have to cath me as a 40-year-old female or male or etc. So big issue. Spasticity or muscle spasms is a big problem for our patients with upper motor neuron spinal cord injuries, and having to deal with medications oftentimes. So we go through the gamut of using oral meds. If oral meds are not effective, typically as outpatients, whether these folks will benefit or need need botulinum toxin injections to help, if it's focal enough to deal with that, versus as somebody that really probably will need a baclofen pump. Being able to, again, talk them through the process as to why they need to consider such a thing to help maintain their spasticity. Because again, for most people, again, the thought being after an acute injury is I'm going to get better. This isn't going to be a problem. But then the longer folks keep living with their spinal cord dysfunction, they realize, wait a minute, maybe there is another option that I should consider. Pain remains also another challenge for us. Again, I think having to decipher acute pain from surgery and the trauma the person has seen, and basically teasing that out from neuropathic pain. What I find routinely is that the neuropathic pain is oftentimes missed or underestimated. Our spinal cord patients will have something we call zone of injury pain. So really, so if let's say I'm a, C4-5 injury, my shoulders will have a lot of pain. And people are like, well, just my shoulders are aching and throbbing. And people just don't realize, well, that's your zone of injury pain. It just kind of comes around and it stays there more so than it's anywhere else, versus that person that has diffuse neuropathic pain that they're talking about, burning, tingling, stinging, whatever it might be throughout the body. So one, recognizing it, and two, them being able to treat it effectively. One of the things I've always challenged my students and residents to, and not necessarily that I recommend this, however, at some point in your lifetime, it's probably a good idea to try some of these meds that we give to our patients. I've been there and done that just because of things that have happened to me over my lifetime, and the medications that we give patients really stink. I mean, they have profound side effect, cognitively, otherwise, GI-wise. So again, you have to appreciate and put yourself in patients' shoes to go, all right, let me help you in managing your pain, but at the same time, being able to manage the side effects of your medication. So what's the greater of the evils? So something to be aware there. And then the other thing we see from a pain perspective, especially where I'm at in Kentucky, a big challenge with our patients, again, that have had substance use disorders, who've been on large doses of either controlled opiates or, heroin and whatnot. And now all of a sudden we have to get their pain under control. So we work with our addiction medicine folks to be able to come up with an appropriate regimen for this patient population, with the goal of really getting away from opiates as soon as we can into some sort of replacement therapy, if at all possible or appropriate. Next thing that we run into is autonomic dysfunction. So after an acute spinal cord injury, for those who've been injured above the T6 level, they will have profound hypotension. They can have profound bradycardia. They will have other autonomic dysfunctions, such as dysfunction of sweating excessively. They will have dysfunction of temperature regulation. Erectile dysfunction technically falls into autonomic dysfunction as well. And so really being able to recognize what's happening acutely, and being able to manage those effectively, because this is the patient that literally you go from lying to just head of bed up 30 degrees or 45 degrees and they're passing out on you. Um, and then forget trying to get them into their wheelchair. So trying to mitigate, how do you manage autonomic dysfunction acutely versus the long term? In the long term, not only are you dealing with blood pressure issues, temperature dysregulations, hyperhidrosis or sweating, but you also get into what we call autonomic dysreflexia, and recognizing blood pressures that are elevating because there is a noxious stimuli. So it runs the full gamut, and we spend a lot of time educating patients. But of course, it never usually hits home until they show up in clinic and they've got a massively elevated blood pressure, and you're like, oh, you're having dysreflexia, and they look at you like, what are you talking about? So once again, having that conversation to say, what is dysreflexia? What do you need to do with it? Understanding risks of uncontrolled dysreflexia, which can include seizures, intracranial hemorrhage, death. I've seen the seizures, I've seen the intracranial hemorrhage. Thankfully, I don't know that I've had anybody who's died from AD, but it's possible. I get a lot of phone calls actually from outside emergency rooms from my patients, basically telling the ER docs, please call Dr. Salles because I'm having dysreflexia, and you apparently in the ER know nothing about it, and call her so she can tell you what to do. I do that routinely. Probably every few months I'll get a phone call from a local emergency room that people, again, just don't recognize dysreflexia. So really important. Overuse syndrome, probably something that we don't see until a little bit later, although it doesn't take long for people to start getting shoulder, elbow, and wrist dysfunction just because of what now they're having to do to compensate for their tetraplegia or paraplegia, depending on what the situation is. So just, again, recognizing good joint health and teaching patients good transfer techniques, wheelchair propulsion techniques, bed mobility, etc. So trying to avoid injury. Pressure injuries are probably one of our biggest nemesis. Things have gotten better from an acute care perspective, but then again, we have chosen our partners well, and have tried to educate our partners in the sense of what is expected from a pressure injury prevention program. So again, turning patients appropriately, making sure that they're sitting on adequate pressure relieving cushions, doing skin checks, avoiding incontinence. What I tell my patients is it's very easy to get a pressure injury. It is super hard to heal one. And, so you can actually technically start developing a pressure injury as early as 35 minutes, 30 to 35 minutes after you've been laying there, nobody's moved you. So it just kind of continues to get worse as you come in with a brand new spinal cord injury. So again, awareness is key. Furthermore, dealing with issues of infections, pneumonia probably is one of the biggest issues that we deal with acutely, especially with your higher level injuries, recognizing once again that folks have profound respiratory insufficiency and don't have the chest wall capacity nor strength to really take that deep breath and be able to breathe in and out. So hospital-acquired pneumonias, aspiration pneumonias because of dysphagia, whatever complicates this significantly. UTI is another big issue that we run into. Again, even under the best of circumstances of intermittent cathing, people will develop UTIs. And there are patients that will have a UTI once or twice a year. And then you've got the patient that literally will never clear infection. But then at the same time, you have to wonder whether the person's is infected versus just colonized with the organism, and what you do with that patient population. And then osteomyelitis, just from the risk of pressure injuries that have gone south, just having that on your radar, that is potentially a big problem. Sexual dysfunction is a potential risk for this patient population. Sexual dysfunction kind of follows bowel and bladder dysfunction. Again, has to do with completeness of injury, has to do with whether you're an upper motor neuron injury versus lower motor neuron injury. So again, being able to have the conversation with patients, you know, as an acute injury, patients have gone through so much loss as it is, you know, and then you have to bring up, and, you know, I will bring it up. I do actually something called Ask the Doctor class with my patients, where we just kind of sit there and go through a lot of these things that we're talking about. And I will bring up the subject to say there might be some sexual dysfunction. And that pretty much opens up the conversation with a lot of the patients that have been wondering about it, but didn't feel comfortable to ask. And so I'll say, I'm happy to talk to you about it, you know, when we meet, or I'm happy to talk to you about it when you go home, after you go home and come back and see me in clinic. And oftentimes people really want to know what's going on and what can be done to help it. Can they have children? What do they do about fertility going forward, birth control in our female population, pregnancy, etc. So, but we try to open the door just to be able to have that conversation. From a bone health perspective, all of our patients that have had a spinal cord injury unfortunately lose about 30% of their bone mass at the time or within 12 weeks of their injury. So if you have somebody who's a little bit older and starting to become osteopenic, that really pushes the osteoporosis. So the risk of fracture becomes much higher. Being diligent about bone health is super important in this patient population. So I will send my patients for bone density studies. I get them to bone mineral health for them to treat their osteoporosis, because once again, these folks can literally fracture a bone just by transferring, hitting the, you know, kitchen table, whatever. So it doesn't take a lot of trauma. I had one guy last month who he was trying to transfer into the car, and his leg got stuck behind him, and snap, it went. You know, and when you're that osteoporotic, nobody's going to fix your fractures either, because you're not going to maintain hardware. So then sitting becomes a problem, and all these other issues. Mental health, big problem, right? I mean, this is a patient population where, again, they have lost a lot. Life as they knew it has changed. For many of them, they're never going to be normal, and being able to help them process through that, you know, and as most things, like kind of stages of grief, people have to be able to go through those stages. I mean, when they first get to me, most people, again, are just, they really don't want to hear it. They don't want to talk about it. We'll have our counselor meet with them, and, you know, counselor would try to tease out, hey, are you okay? Do you need anything? And they're like, I'm fine. I don't need anything. But you can kind of see that that's not necessarily the case. Like I said, we offer counseling to all of our patients acutely. We try to set them up with peer support, and peer mentors, to have somebody else who's been through the situation talk and have a resource, and then make referrals for ongoing mental health. A lot of my patients, I would say, at some point or another are on an antidepressant. I take the advantage of using Cymbalta to not only help neuropathic pain, but from a mood perspective to help some of the depression. Like I saw one of my guys today who's 22, and I said, what are you doing? Because I hadn't seen him in a year. And he's like, nothing, I'm done. I can't do this. And you know, so we sat back, and basically the whole visit was revolved around how he was going to pursue going back to school, being able to get a job, going back to therapy, you know, actually taking an active role in his life. So we do a lot of counseling as well as part of our sessions to just make sure people are doing okay. The risk of suicide is not to be underestimated. Probably a good 35 to 40% of our patients will at least attempt suicide within that first year after spinal cord injury. And I've had a few through the years who have successfully, you know, committed suicide. And so we've had the ones who've attempted and those who have committed suicide. So again, it's not to be taken lightly. Metabolic syndrome. So if you think about it again, with a new injury, you've kind of lost control of a lot of things, but your hand to mouth typically works pretty well for most people. Even those who are tetraplegic figure out a way to do this. And so if they can't control anything else, they can control what they're eating, and they will eat a lot. A lot of our patients will lose a good 20 pounds initially with an acute injury, but within the first year, most of them are gaining 50 pounds plus. Some of our folks are not necessarily small people to begin with, so having them understand what the ramifications of gaining weight will mean. So one, it's, again, risk of metabolic syndrome, and the risk for glucose intolerance is much more profound compared to the able body. Our risk of coronary artery disease becomes higher. But just the gaining of the weight, what people don't understand is that they are not going to fit into their definitive wheelchairs. So a wheelchair that's ordered that takes you 3 months to get, if you manage to gain 30, 50, whatever pounds, when you get that chair, you're not going to fit. And your insurance probably isn't going to care that you were depressed and you decided to eat yourself into that state. And now you're getting pressure injuries on your greater trochanter because your chair is too small. So it's a challenge of making people recognize that that extra weight is not helpful from that sense. It gets in the way of them trying to transfer. I mean, transferring is hard enough. Adding more weight to that becomes even more challenging. So really just being aware of what that gaining of weight means. It's super, super hard to lose it because once again, you've got a patient population that, one, likely doesn't have good access to any form of exercise equipment, and two, again, they can't burn it despite what they're trying to do. So it becomes a lose-lose situation. So trying to just have them have a little bit more self-perception of what they're doing for themselves. Looking at mobility, again, the primary goal for all of our patients obviously is I want to walk again. Unfortunately, that is not necessarily a goal that is achievable for all of our patients. So figuring out how best they can be independent with mobility. So whether it's they're going to be walking with an assistive device or bracing, fantastic, versus no, you need a really good manual wheelchair to support you, versus no, you need a really good power wheelchair to support you. But again, looking at how do you make your patient functionally independent based on what their level of injury is and what they're capable of. So again, that equipment determination is super important, realizing that the equipment that we are ordering for my patients, a K5 manual wheelchair, which is an ultralight chair, costs about $7,500. A power wheelchair with tilt and recline, leg elevation, is upwards of $25,000 to $28,000. And so you have to get it right, because if we screw this up for them, they're going to get stuck with that piece of equipment for probably 5 years. And so again, we have to make the right choice for them. Then we go into vocational and social issues. Again, like I mentioned, a lot of people, and again, you have to put yourself into their shoes to go, how would I do this? I live in a state where things are rural, things are not necessarily accessible, educational levels are not great, literacy is not great in general, access to everything is a problem. So if I'm sending a new tetraplegic back to a remote county where the patient doesn't even really have public transportation, what is the expectation of going back to vocation when they were coal mining, and that's what they've known their whole adult life. So again, trying to help them navigate the system to go, all right, what is out there for you? What can you do based on your injury? Because again, there's tons of people with spinal cord injuries that can return back to work if the right environment, getting vocational rehab involved in their care, and making accommodations. So it is feasible, it is possible. We'd like to encourage people to do that. But again, it all depends on all these other factors that we've talked about already as to whether you're successful or not. Exercise and ongoing therapy. There is not enough therapy in this country to support our spinal cord injury patients. We continue to deal with shorter and shorter lengths of stay from an acute inpatient perspective. Then, our goal is to try to keep them for as long as we can to get them functionally independent at whatever level. And then it's the determination of transitioning to home health versus outpatient, keeping those disciplines going for as long as their insurance will approve. We are running into more and more challenges of getting home health services for most of our patients because we are a heavy Medicaid MCO state, and they don't contract well with a lot of the home health agencies. They don't pay the home health agencies well. So most of the home health agencies are like, forget it, we're not doing this. So again, looking at what's available and resources in your community, super helpful. Our therapists do a fantastic job of providing patients and families with a home exercise program. So if they kind of get into a situation where really nothing is available, at least they know what it is that they need to be doing. And exercise is a whole nother debacle that we deal with because majority of your local gyms are not wheelchair accessible. I mean, next time you walk into a gym, kind of look around and figure out which one of the equipment that you have is actually wheelchair accessible and appropriate and safe for somebody in a wheelchair to use. There's not many. And so one, that is an issue. And two, again, for a lot of my patients in particular, once again, access to the gym as far as transportation to a gym is nearly impossible, or does their community even have a gym that they can get to? So challenging patients as to how they can exercise. Thank goodness nowadays for YouTube and other venues out there that you can utilize to help tell patients to, do CrossFit in their wheelchair and other things that they can participate in to get them some exercise. So again, there's a lot of creativity that comes in from a spinal cord injury perspective. And then understanding the physiologic changes and aging with spinal cord injury, huge amounts of physiologic change that we take for granted, and honestly not well understood, but just the whole concepts of autonomic dysfunction on the body, like what is the long-term side effects? Like I said, poorly understood, but we see them all the time. Patients that have, for example, uncontrolled autonomic dysreflexia will end up with heart arrhythmias of AFib and heart failure and whatnot. And you can't generally use the same medications that you do in an able-bodied population because, like if you were to put somebody on an ARB or an ACE inhibitor because they have congestive heart failure, and like you do in an able-bodied person, you put that on somebody who's a spinal cord injury, their blood pressure is already low. So the tolerance to those medicines becomes piss poor. So again, you kind of get into the situation of what is the greater of the evils? What do I need to treat? But the whole point of our spinal cord injury medicine and caring for our patients is let's avoid those long-term complications as much as we can. So that was a lot. Sorry, let's see. All right, so as far as how did I get here, which is, I realize, a big transition, but so I ended up doing a residency here at the University of Kentucky. Just as an aside, I wasn't going to do PM&R to begin with. I had a different path that I had chosen for myself, and somebody else decided otherwise for me, but I was lucky enough to have done PM&R as a second to last rotation as a fourth year student. So I knew what PM&R was about. And at the time, basically ended up scrambling into PM&R, which is probably the best thing that has happened, or one of the best things that have happened to me over my lifetime from a career perspective. So it landed me here at the University of Kentucky, where I did my residency program. I then joined UK for a year where I did general PM&R and stroke rehab. That I became boarded in spinal cord injury, and then life changes moved us to Boston, where I ended up getting a job at Spalding Rehab Hospital. Again, I was hired initially to do stroke rehab, but within 6 months of being there, their spinal cord injury doc left. And for those of you who know Dr. Frontera, he was my chair at the time, and he basically looked at me and said, Sara, I think you would be great at this. Do you want to do this? And I said, sure, why not? Because again, I felt like I came from a really good background with having learned spinal cord injury medicine here at UK to begin with. So I felt relatively comfortable. And again, I knew who to call if I had questions. So because of the work that I ended up doing at the time and the large patient population that I cared for in Boston at the time, back in those days, you could either do a spinal cord injury fellowship, or depending on the number of patients or volume that you cared for with spinal cord injury and disease, automatically grandfathered you in to allowed to sit for the spinal cord injury medicine boards. And so I was of that schooling where I basically taught myself a heck of a lot, and then got boarded. Actually, I have to retake my boards again this coming year. Yay me. So, that was something that I added and I decided I wanted to do. And then had the opportunity after I came back to the University of Kentucky in 2004. In 2006, I took over our spinal cord injury unit, and basically do primarily spinal cord injury and disease. I would say is 80% of my practice. The other 20% is other neurodiagnoses, and then a lot of spasticity management, as well as I dabble in movement disorders and management of deep brain stimulators. I do a lot of amputee care and then burn care. So again, I've had some smaller subspecialties that I've done throughout time as well. So I do inpatient care 5 days a week. I do outpatient spinal cord injury follow-ups, plus my other myriad of patients. I have 1 day of clinic that I do primarily as a procedure day, where I do my botulinum toxin injections and pump refills. We have the largest pump program in central Kentucky that we're very proud of. And then the other 2 days are primarily just follow-up visits for my patients. From a SCI or spinal cord injury fellowship currently, it is a 1-year clinical fellowship. There's currently 25 programs in the US. You can get to spinal cord injury medicine from other routes besides PM&R, so anesthesiology, emergency medicine, family medicine, neurology, neurosurgery, plastics, and urology. I've personally never met anybody that has come that route. I've met neurologists that have done a neuro rehab fellowship, but I've never met anybody that has done an SCI fellowship indirectly like that way, besides going from PM&R. Again, the candidates currently are participating in the NRMP match process. The match occurs in the fall, and usually the positions are to start in July. Majority of the applications and review process and interview processes, this going on this time of year. They typically start earlier in the year as far as starting interviews, probably I would say mid-spring going forward. So they went to the NRMP match probably about, I want to say 5 or 6 years ago, whereas before that it was just a nice little lovely interview that used to get done. And then ASCIP, which is our organization, they have information about the fellowship. They are happy to have residents, students come to their meetings annually. That meeting is typically in September. This year it's September 7th through 10th in Kansas City. It's usually a great meeting because it is a multidisciplinary meeting with PTOT, case management, nursing, physicians, pastoral health, and a variety of different people, urology. So it's a really nice meeting. But if you needed more information, these are the two folks that direct primarily most of those questions as far as fellowships are concerned. You know, and again, why do I do spinal cord injury medicine, and why should you do or consider it? I love my patient population. They are extremely challenging, but in a good way. I am never bored. And that's what I really enjoy about them, is that no two spinal cord injuries are ever the same. You know, and it's trying to get people as functional as possible. And really, it does take that person to be able to not only do spinal cord injury medicine, but have a good fund of knowledge of general medicine, be comfortable in your skin from a psychosocial perspective, and really being able to counsel patients. You know, so I've learned a lot through the years from my peers, meaning all my therapists, nursing team, case management, counselors, whatnot. Because again, it requires you to kind of think on all cylinders and be able to help your patients as much as you can. Again, you have a very diverse patient population. The other thing that kind of is a little unique to probably what I do, not necessarily something that you would see throughout the country, but I care for basically, or willing to care from babies to octogenarians. So I really don't discriminate based on age. I have a fair number of pediatric spinal cord patients that I've cared for over the years. That one honestly has to do with your comfort level and your knowledge, once again, as far as pediatrics in general, because you cannot think of them as small adults, as their physiology is obviously different. And, you know, at the end of the day, you know, being able to impact patients' and families' outcomes, improving their quality of life, I think is super important. The other thing that I do quite a bit of is a lot of advocacy. And I do advocacy in the sense of, you know, I've gone to court to speak on behalf of a patient in the past where their parental rights were being discussed because of their spinal cord injury, not because of anything else, but because of the fact that the person was a tetraplegic and that they should have their parental rights, you know, removed from them. I think I drove 3 hours for that one. You know, I spend time calling and talking with medical directors of insurance companies, trying to get approval for equipment that gets denied. I call for denial of inpatient rehab for my patients. We argue about the number of catheters that patients deserve and should have. Because again, I think that's, I mean, it's important to me for my patients to do well. And then lastly, one of the other things that I think makes my job fun is that we do a lot of education for other healthcare providers, for patients, for families, just to understand about spinal cord injury medicine and to be a resource to those out there and to be able to field those phone calls and answer whatever you know to do. So again, those are some of the reasons that have come to me over the years. So it's been a blessing. And, you know, pictures I think are worth it. So these are some of the patients that I've cared for over the years. Gentleman who's on the rock climbing wall, he was a para. We actually had a day where they brought out the rock climbing wall demo out to Cardinal Hill, our rehab hospital, and he was out there doing it. Gentleman on the lower right in my right hand corner, you know, is doing archery, adapted archery, and then we've got skiing. And then the picture on the top is actually me and our team we've done a mission trip to Ecuador through Shoulder to Shoulder, which is a program here at UK, which is fantastic. Even if you're not at UK and you want to join it, it's an amazing experience. But I had the opportunity to go down there and do home visits and work with individuals with spinal cord injury. You know, again, you can see the environment where this person is living in. You can see the wheelchair is, you know, a bunch of garbage, but better than what she otherwise had. She literally is living in a house. This is one room. They had another room there, having to be able to deal with it. She had a Foley catheter, one that you would never see in this country, that was so small it wasn't draining anything. But again, just being able to be there and talk her and her family through what we needed to do to keep her as healthy as possible. So it was a fantastic experience. And the people standing behind me, we've got a dietitian, we've got PT students from both Ecuador as well as the US. We had a pre-med student who has subsequently joined the UK med school. So again, it was a fantastic group of people to take with us. So I think that's where I end. I'm happy to entertain any questions.
If anyone has any questions, feel free to either type them out in the chat, or you can unmute yourself. I think you have the ability to do that, and just fire away. And if no one has any questions, I do have a few questions from the sign up sheet. So I'll let people talk first and then I'll read. Maybe I'll just start off with the questions. Okay, so this one we kind of already answered, but I would imagine specializing in spinal cord injury lends itself to primarily inpatient work. Are there options for fellowship trained SCI specialists to work outpatient?
Yeah, I would say majority of us who do spinal cord injury medicine, and there's not a lot of us throughout the country, guys. We have 3 in the state of Kentucky, if that tells you anything. Okay, and out of the 3, 1 is at the VA, I'm at UK, and then we have another one at the University of Louisville. So again, there's not enough of us. We do a lot of primary care for our spinal cord injury patients as well. So you've got to be okay and comfortable with that. You could probably technically do an outpatient practice only. I just like it because I have that long-standing relationship with my patients, from knowing them and getting to know them, their families, their kids, their dogs, or whatever, from inpatient all the way through. So that when they come in to see me, I have that history of where we started together and the challenges that they've been through. And so you celebrate the good, and I don't know. So that's been my preference. Could you do it as outpatient only? Probably.
Okay, another one. Let's see. Common pathologies you already covered. You already answered if you do acute versus chronic. I guess you also kind of answered this one. What other healthcare workers do you primarily interact with? You kind of already mentioned that. Here's a fun one. How to differ spasticity from brain lesion and spinal cord injury based from pathophysiology, so you can plan the management. I feel like that's just a whole nother lecture in itself.
That is a whole nother lecture. So I think, okay, so the big thing to think about, guys, is that brain injuries are never clear cut, meaning, generally speaking, when somebody has a brain injury, it's not just one little spot, unless it's a stroke, right? But if you've had a diffuse axonal injury, a coup contra coup, I mean, just by definition, your brain has shifted. And so you've got midbrain, you've got cerebellum, you've got frontal lobe. I mean, so you get all of that involved. And so the patient with a brain injury oftentimes is a mixed picture of spasticity and dystonia, versus the spinal cord patient, if they're just a spinal cord, is only spasticity. Okay. And again, the definition of spasticity is that it is velocity dependent. Dystonia is not velocity dependent. All right. And so you have to, as you get to moving people and understanding tone, you get a better understanding of the rigidity that you see with dystonia versus don't get me wrong, you can have somebody with a modified Ashworth of 4 that is rigid, right? And at that point, you have no clue as to what the heck you're dealing with. But once again, you go back to what was the insult. Now, I have patients that are dual injuries, meaning that they had a brain injury along with a spinal cord injury. Majority of my patients that are dual injuries, for the most part, thankfully, are mild traumatic brain injuries along with their spinal cord. So there's mild cognitive dysfunction, but you don't see the long track signs as far as dystonia or spasticity, being worried that you're worried that it's coming from the brain. You know, mine are clear cut. You had a C5 injury, you had a T4 injury, you have a T7 injury, whatever, it's coming from there. And it's very different. And the other thing is looking at their, the way that they posture. Again, spasticity and dystonia looks different. So that just comes with experience and time. And there are patients, again, that are dual injuries that you're going to probably have to treat both of those issues. And we do all the time. So that becomes a little bit more of a game, because then some of those patients also have other movement disorders that you can unveil when you take away their spasticity, and you'll bring out things like chorea, okay, and hemibolismus and things that you did not want and weren't planning for. And now all of a sudden you're like, oh God, what happened? So, because the spasticity was masking it. Good question.
So here's a chat from Renato. Oh, go ahead, Grant. Sorry, go ahead.
You mentioned the importance of bowel and bladder, like routine. So if you have a person with like an upper motor neuron lesion, what's a good example of a routine for that?
So from a bladder perspective, the biggest thing from a bladder perspective is that you have to have a way of emptying your bladder, right? So one, it's you want to promote continence in the sense of not necessarily that I have bladder control, right? Because these folks won't necessarily have bladder control, but you don't want them to be leaking all over themselves and sitting in wet pee. So, I think it's really important and reasonable to have a conversation. And sometimes it takes repeated conversations until people buy in and figure out what they want to do. I think when I first started off, it was like, everybody needs to learn how to cath. Well, that's fantastic and a really nice concept, but is that feasible for everybody? No. Okay. So again, you have to step back from the picture and go, what is the patient's hands capability? What is their postural control? What is their belly look like? I mean, if I have a lady that has a massive pannus, there is no way that she's going to be able to self-cath. Okay. Again, that's not to say we're not going to try, because we do, but it's like not working. Right. So, I mean, you have to look at those factors. Look at, can the person transfer? Can the person, cognitively follow enough directions to be able to do that? So it's essentially two choices to begin with, which is you can do an indwelling catheter versus you teach people how to intermittently cath. And the catheterization is based on volume. The goal is to cath no more than every 3 hours with volumes less than 500. Because as volumes get higher and higher, you're having to cath more and more. You cath more and more. You have trauma. You cath more and more. You have UTIs. So you have other problems that you're worrying about. So again, you're having to balance that. And I have some patients that, they come over to me, they have a Foley, they'd like to learn how to cath. So we take the Foley out, we start intermittent cathing, and then the next thing you know, they are cathing every 3 hours for a liter, and you're like, not doing this, because you're having to also worry about bladder pressures and backwash and reflux into the kidneys, which will then cause hydronephrosis. So that's not acceptable. So really, truly a holistic approach to your bladder care comes into play here. And then the patient who, let's say, says, I want an indwelling catheter, that's fine, we'll do that. All of my patients are referred to urology. All of our patients get annual ultrasounds to look at bladder and kidney health. For some patients, they will decide, I want an indwelling, but I don't want it through my perineum, so I need a suprapubic catheter. Versus the patient that wants a continence stoma so they can cath themselves, but they don't have to worry about dealing with clothing and all this other management as a female. So perhaps they might be appropriate for that. So again, there are things to consider and walk patients through and talk them through it, and introduce those concepts, but everything has a time and a place. But really, so your first line of defense is figure out a way, how do you keep the bladder and the kidneys safe, empty it, figure out the frequency in which you need a cath. Your lower motor neuron folks are a little bit more tricky because bladder is fairly hypotonic, but then the other challenge is that your sphincter is hypotonic as well. So there are some patients with lower motor bladders that they can just crede and bear down and empty their bladder, no problem, and that's it, and they're good. And then there's the patient that is literally every time they bear down, whether to go to stand or whatever else, they're just leaking tons of urine. So really, again, it's understanding your bladder dysfunction. So it might be that patient, again, is offered an indwelling catheter to keep themselves dry versus intermittent catheterization. So once again, maintain dryness. So it just depends on the patient. I will have all of my patients undergo urodynamic studies through urology as well, because again, I think that helps them to get objective evidence to go, look, this is your bladder pressure. This is what your bladder's doing when you have this much in your bladder. So the patients get to see that and they're like, oh, yeah, that wasn't really good. So again, working with a urologist who does neurourology, those are tough people to find, but super, super important. And then there's a whole thing about drugs when it comes to bladder care. That's a whole nother lecture too. So, yeah.
Thank you.
No problem.
Renato put in the chat, oh, my camera's not on. I was wondering if there were any common examples of adaptive or modified devices / equipment that SCI patients use for ADLs in your practice. You kind of touched on it. That's another lecture.
That's a whole nother lecture too. So there are, from simple things that you all may or may not have seen on other rotations, things like your socket. Again, it just really depends on what level of injury you're dealing with, right? If I've got somebody who's tetraplegic who, let's say, has some elbow flexion, maybe a little bit of wrist, but has no finger flexion, this person can stab at their food and be able to eat. Okay, so it might be that I have what's called a universal cuff that they put onto their hand, where they literally put actually on the side where the spoon or the utensil will come out of it, and so they're stabbing to bring to their mouth. Or they could, for example, put a stylus in that to just be able to do something on an iPad. Or be able to use it to kind of stab at a keyboard, for example. There is something called a wrist hand orthosis, which literally, they have to have wrist extension, but that'll put them into a 3-point chuck to be able to hold a catheter or to be able to hold a pencil once again, or a pen, to use their arm. There are things like plate guard. So again, if I'm just stabbing at my food, but I don't want the food to fly off the plate, I put a guard on my plate so my food doesn't go flying. There's there's rocker knives to cut things if the person has some of this but doesn't have enough fine motor control. There's adapted wash mitts. There's adapted handles or scrub brushes to like wash your back. We have adapted suppository inserters. We have adapted digital stim aids that we use for bowel care. So again, there is a whole world out there. The challenge being is, does the person have the funds? Because these things, for the most part, become items that patients end up having to buy out of pocket and not covered through insurance. I mean, insurance is going to cover your wheelchair if you're lucky. They're going to cover your cushion. They will maybe, depending on your health insurance, cover bathroom equipment. A lot of the insurances don't cover bathroom equipment because, hey, taking a shower and going poo is a luxury apparently and not medically necessary. So again, so some of these things become out-of-pocket expenses. Some of them are not that expensive, and other things like, a tilt and space reclining shower chair that is padded is $1,500. I mean, most of our patients don't have that kind of money that's sitting around, nor do they have the adapted shower, for example, to roll into to then sit on that shower chair, so to speak. So again, it's like I said, this is where I've learned to become very creative, and the people in my life, as far as my team, is very creative. We have learned about, our state resources, who gets donated equipment, refurbishes things. We have something called HDI CATS here in Kentucky. We have another program called Project Carrot. So we'll reach out to those organizations all the time to go, hey, I need something like a ramp. I mean, hell, because again, patients think that their insurance company is magically paying for them to have a ramp for their house. And it's like, nope, that is a personal expense. So again, it's variable. And really, again, it goes back to level of injury, because not everything is appropriate for every person. And like I said, there's a lot of equipment out there, and some of it honestly will get tossed to the side because patients figure out other ways to do it easier and just less cumbersome without equipment necessarily. So every case is unique as to what they end up needing or using.
That's it, I think.
Well, if anybody has any questions, Brandon can share my email with you. So feel free to just reach out, whether it's about spinal cord injury, medicine, anything general related to PM&R, anything in particular about our program, whatever. So I guess the one thing I didn't throw in here as far as the many hats that I wear is I'm the course director for our RBM 850, which is our acting internship here at UK. And I've done that for a number of years. So I recognize some of the names on the screen. So, well, thanks for having me, guys.
Thank you so much for talking with us. You're the best.
Thanks.
It's good to see your face.
Good to see you too. Bye, guys.
Stop the recording.